Hey guys, it's Shay and Chris, and today we're going to talk about pacing.
The pads that we use here at LifeLink are the Curaplex. They're a multifunction defibrillation pad. Not only can we use these for defibrillating patients in cardiac arrest, but we can also use these for pacing patients as well. They're specifically made for Zoll, so it plugs into the Zoll connector.
Wow, the airport is very busy today. So there are a few different situations where we might want to pace the patient, but ultimately symptomatic bradycardia is one of the most common reasons. And we see that a lot sometimes on our heart attack patients, OMI, STEMI patients. Sometimes when we have damage to the coronary arteries, it impacts the electrical conduction system. You end up with a heart block, you end up with bradycardia. And so by pacing them, we're basically overriding that conduction system, giving a new electrical impulse, asking the heart to beat faster, and hopefully get their blood pressure up so that we can keep good perfusion. And Chris is going to show you on the monitor how we do that.
So on your Zoll X series monitor, once you turn it on, you have the pacer button down here. So once you go and click that, it'll give you multiple options here. We can do demand for the mode, or we can do fixed. Fixed meaning we set the rate and it stays that way. Demand meaning it only does it when it's needed. 90% of the time we're going to be doing it in a fixed setting. So we'll go to fixed. You select that with the scroll wheel here. Your rate, typically for most programs and most EMS agencies, we're going to go to about a rate of 80. And then you go to the output. Ours defaults at 30. You're going to keep going up, goes up by about 10. And then you go until you get both electrical and mechanical capture. You'll see the electrical capture on your isoelectric line. You'll see a pacer spike, and then you'll have a subsequent QRS that follows. What you want to do then is once you have your electrical capture shown, you want to check their carotid or a major artery to see if that correlates with what you're seeing on the monitor.
Or what else?
Or
ultrasound.
Or ultrasound as well.
Yeah, we love ultrasound.
So then once you set your rate and you see that you have everything where it should be, typically you're going to put your output about 20 or so above what your rate is. That usually guarantees you, it's a pretty surefire way to guarantee you both mechanical and electrical capture. And then you start the pace. So then it'll show here these P's is where it's showing that the monitor is actively pacing at this time. And then with that, you should see subsequent QRS complexes with each of those. Again, there's multiple ways to confirm both electrical and mechanical capture, ultrasound being the gold standard in our field. However, if you do not have access to ultrasound, you can do it by checking your carotid or femoral arteries to see if you have a pulse that corresponds with the
Do you always
spike.
start your output that high?
Usually.
Really? I feel like I usually start it low and then work my way up.
Well,
and then once I get it, I go up like a little bit more.
Yeah, so and that's what I'm saying. Is like once you get it close enough to where you start seeing electrical capture, confirm that you have mechanical capture, and then you usually increase it by about 10 to 15 milliamps, and that's where you kind of leave it. So it gives the body a little bit of wiggle room to play with.
Nice. All right. So there's a couple of different ways that you can place your pads. There's anterior, posterior, and then there's interior, lateral. Now, if you are pacing, typically if we do AP pacing, studies show there's like 80% capture that way. There is better capture a lot of times with AP pacing. Sometimes you have to work around a larger body habitus. But interesting fun fact, if you are doing something like converting AFib, the EPIC, I think it was the EPIC trial, showed that anterior lateral placement had like 54% success conversion to sinus rhythm versus AP, which was like in the 30s. So there are times when one is superior to the other, but in general, AP does tend to be the more superior placement because of the ability to get electricity to the heart in this placement.
So it's also kind of about vector changes here with AP versus anterior lateral. So even in cardiac arrest patients, especially with AHA bringing back your dual sequential defibrillation, that's where you're kind of playing with vector changes and how the electricity is going to go through your heart.
Sweet. All right, guys, that's our little short video on pacing. I would say don't be afraid to do it. If you are able to get the patient's heart rate up and get their blood pressure up, everything we do is about perfusion, right? Because without perfusion, we're not getting oxygen-rich blood to the body or to the brain, and then what are we doing, right? So a lot of times in our STEMI patients, especially if they're really sick, we put the pads on ahead of time because on somebody that has a high chance of going into a arrhythmia, we don't want to have to be fumbling for our pads, so we'll place them on ahead of time. That's all for today. Bye!
Okay.